I'm going to try to keep this pulmonary complications short and sweet. Keep in mind the book is going to go into way more detail than what you need. So you want to know the conditions outlined in this PowerPoint video. You want to know, be able to define them, what they are, and then basic management of them. Good rule of thumb for all neonates is you want to keep low peak pressures. You want to keep your FiO2 as low as possible or be conservative with your FiO2. You also oftentimes will use the oscillator primarily when you're having problems oxygenating. Any condition that keeps the patent ductus arteriosus open, you're going to possibly run into persistent pulmonary hypertension, which means you're going to possibly need your nitric or your other pulmonary vasodilators, and those would be the conditions that would be most likely going to ECMO if they don't turn out well. Atelectasis. This is a condition no different than adults. It's a collapsed or airless condition of the lung. You know the reasons why they occur. In neonates, you often will see this with meconium obstruction, lung compression from lung masses, tumors or gastric contents, or just respiratory failure. Atelectotrauma is injury to the lung as a result of repeated collapse and re-expansion of the alveoli, one of the major causes of lung injury in mechanically ventilated neonates. This is part of the reason why they will switch to the oscillator right away, is because it keeps the alveoli distended and it recruits them. Here's a picture of a neonate with atelectasis to your right, and notice it's in their right upper lobe. Clinical signs of atelectasis in an infant or neonate is going to be grunting. Anytime you hear grunting, that is the baby trying to create more PEEP within themselves, okay? Cyanosis, tachypnea, nasal flaring, retractions, increased FiO2 requirement, decreased trends in mechanical or spontaneous tidal volumes despite an unchanged PIP and PEEP, hypoxemia, and then your chest radiograph will reveal areas of increased opacity where alveolar units have collapsed and are not air-filled. If severe, the mediastinum may be shifted towards the collapsed side. Remember, the key features of respiratory distress in a neonate includes tachypnea, nasal flaring, retractions, and grunting. Management and treatment of atelectasis. You want to extubate as soon as possible after mechanical ventilation. You want to use good airway clearance techniques. You want to do frequent changes in patient positioning. And CPAP is an effective method to recruit collapsed alveoli and provide alveolar stability, especially when extubated. You can deliver this via nasal prongs or mask. Initial CPAP pressures are 5 to 7. Provides positive pressure that increases the functional residual capacity, lung expansion, and lung compliance, and it decreases airway resistance and work of breathing. Now notice how CPAP treats a neonate is no different than how it treats an adult. The only difference is we probably aren't going to use as high of pressures on neonates. So we're not going to focus a lot on the mechanical ventilation aspects of our neonatal diseases because basically you want to keep your peak pressures low, be conservative on your FiO2, and so on. Pulmonary interstitial emphysema. You are going to see this on occasion. It's not super common, but it's not rare either. It's abbreviated as PIE. It's the dissection of air into the tissue of the lungs surrounding the pulmonary vasculature. So if you think of what airway edema is, or pulmonary edema, this is like that, except where there would be fluid in pulmonary edema, there is air in PIE. So it's crazy. It's an acute pulmonary complication seen most frequently in premature infants with RDS requiring mechanical ventilation. PIE develops as a consequence of overdistension of the distal airways and alveoli. PIE normally manifests as hypoxemia, hypercapnia, hypotension, and episodes of bradycardia. If you notice in the chest x-ray to your right, you can see the irregular densities appearing predominantly in the right lung. That is where the interstitial emphysema is. Management and treatment of PIE includes minimizing any overdistension of the lungs in respiratory distress syndrome patients. That's the best way to prevent it. If it develops, or even before it develops, you want to, again, keep your PIPs, PEEPs, and I times low. You want to use volume-targeted ventilation, avoid auto-PEEP, and if you need to, switch over to some high-frequency jet ventilation. Okay, pneumothorax. Again, a pneumothorax is air in the thoracic cavity, just like it occurs with adults. Same things will happen as adults as far as tachypnea, hypoxemia. Other symptoms include abrupt duskiness or cyanosis, hypotension, bradycardia, hypoventilation or apnea, decreased breath sounds on the affected side, decreased heart sounds, bulging of the affected hemithorax, a mediastinal shift to the unaffected hemithorax, and asymmetric chest wall movement. So again, the signs and symptoms are really no different than an adult, and our treatment really isn't different than an adult either. Here's a picture of a neonate with a tension pneumothorax on the right. One of the techniques they will use to identify a tension pneumothorax, because we need to intervene immediately, is called transillumination of the chest. And this is where they take a high intensity light source and put it usually on the back of the baby on one side, and then compare it to the other side. And if the lung area on the front of the chest lights up, then that means that's where a pneumothorax is, a tension pneumothorax. So again, we will use transillumination of the chest to identify a pneumothorax or a tension pneumothorax when we need immediate intervention because the patient is declining quickly. Management and treatment, again, similar to an adult. If it's a small one, it can resolve on its own. If it's a tension, we need to do some needle decompression, or the physician does. We don't do that. They sometimes will include a chest tube and connect it to continuous suction, set it anywhere between -10 to -25 centimeters of water pressure. Pneumomediastinum, this is something we do not see in adults. Typically, we may rarely, but this occurs when extra-alveolar air dissects through the lung and then ruptures into the mediastinum. So if you see on the picture to your right, you see there is a pneumothorax on the left, and then the arrows around the heart, you can see a dark line kind of around the heart. That is air in the mediastinal, and it's lifting the heart away from the diaphragm. Causes of this include airway obstruction, mechanical ventilation, infections, obstructive lung disease, trauma, and Valsalva maneuvers. Symptoms are going to be very similar to a pneumothorax as far as tachypnea. They could have a bulging sternum, distant or crackly heart sounds. That is unlike a tension pneumo. Cyanosis, respiratory distress, and they may develop subcutaneous emphysema. Diagnosis is made with a chest x-ray, which will show the free air in the mediastinal space. Treatment without the presence of other pulmonary air leaks. Okay, pulmonary air leaks is a pneumothorax, but if there is no pneumothorax, then it does not require aggressive therapy. You can closely observe it, and then you want to minimize any pressures you're delivering. So really be conservative on your PIPs and your PEEPs. If there is a pneumothorax, you need to treat the pneumothorax, again, keeping your pressures minimal. Pneumopericardium. This is air within the pericardial sac. This is a rare and life-threatening event in the neonatal population. Tamponade will develop, which impairs the filling of the heart during diastole and impedes cardiac output. Signs, again, will be the simple signs of respiratory distress, as well as muffled or absent heart tones. The arterial blood pressure will decrease. Peripheral pulses will disappear. The heart rate will drop, and they could go into pulseless electrical activity. Definitive diagnosis is made with a chest x-ray, and it will show a broad radiolucent halo completely surrounding the heart. And if you look to the picture on your right, that is a perfect example of it. Pneumonia, again, pneumonia is no different in babies than it is adults. It's an infection in the lung. It can be a bacteria, virus, or other organism. Some maternal factors which could lead to pneumonia in the newborn is if the mother has had rupture of membranes, especially if they have been ruptured for over 24 hours. Maternal fever, chorioamnionitis, which is an infection of the amniotic fluid. Some common organisms in the neonate population when they have pneumonia is group B streptococci, or GBS, and that usually comes or is present if the mother's membranes have been ruptured for over 24 hours, but not always. Gram-negative bacteria, and then the rest are not so important to know. Management and treatment, again, very similar to take than that we do with adult. Right away, you want to screen the mother for the GBS and administer prophylactic antibiotics if possible. You want to administer maternal and neonatal antibiotics as a routine management if chorioamnionitis has been identified. You want to promote good hand hygiene. You want vigorous antibiotic treatment of mothers with ruptured membranes or of premature labor between 22 and 26 weeks. And then other than that, just like adults, most of our management is supportive. You want to oxygenate them conservatively, ventilate them with minimal pressures, thermoregulate, give them fluids, nutritional supplements, and broad-spectrum antibiotics. This concludes this video over pulmonary complications in the management. Again, our focus is on knowing what each complication is, the general management of the patient, as in, are we going to give them antibiotics or do we need to do a needle decompression and so forth. Diagnostic tests, you need to know that transillumination, know all the other PEIE, pneumomediastinum, pneumopericardium, those all require a chest x-ray. So a pneumothorax is the only one that you can do the transillumination. Okay, that's it.